So it's my pleasure tonight to introduce Airlift Northwest. We talk to Airlift Northwest all the time as obstetricians. I know that you guys see all the, the drama stuff and the trauma to Harborview, but we also talk to as an obstetrician, it's actually safer to transport the baby and mom to a high-risk center than to transfer the baby. So it's my pleasure to introduce Airlift Northwest to you today. And to that extent, you will hear Brenda Nelson, RN. She's our chief flight nurse for Airlift Northwest. And she provides the daily leadership and operation management for all the aspects of air transportation organization. And that is one big job, at least, God, the phone calls that we get, making sure that baby and mom are safe for transport. She's worked at Airlift Northwest since 1996. Started as a flight nurse, a neonatal specialist, so she was transporting babies, and then advancing to the assistant chief flight nurse in 2001. Prior to that, she worked in the emergency room departments, the neonatal ICU, and ground and ambulance settings in Washington, Montana, and Connecticut. So she's been with us, the UW Medicine, since 1990 as a staff nurse or a charge nurse. She graduated from Montana State University, which was where she discovered the love of flying of patients. And her hobbies include her family, sewing, gardening, and cake decoration. So it's my pleasure to introduce her to you tonight.
Well, thank you for having us tonight. And we came here to talk about an area of medicine that's not very well known, and it's a highly specialized area. I brought quite the team with me to talk about the challenges and the adventure of flying for Airlift. And we'll give you some more details as far as that goes.
When you call for an Airlift Northwest helicopter, what you're looking for is speed and expertise.
We travel approximately 160 miles per hour to get to the scene quickly, provide inter-service hospital transfers in a timely manner.
Since 1982, Airlift Northwest has transported over 80,000 patients from a four-state region. We have 4 helicopter bases strategically placed around the west side of the state, one in Bellingham, one in Arlington, one in Seattle, and one in Olympia. And we have 2 Learjet bases, one in Juneau, Alaska, and one in Seattle.
We've got night vision goggle technology for all the crews. We have onboard weather radar, a GPS moving map technology, satellite tracking, and communication systems to stay in touch with the operations center.
Airlift Northwest also offers what we call an air care membership. People are transported by Airlift Northwest in 2 different ways. One would be from the scene, in which the fire department calls Airlift Northwest when they're either on the way to or come to the scene of a serious accident or some kind of traumatic event. The second way would be if you are already in an existing hospital, but you need to go to another hospital for other services.
Landed here, we've gone in to go get the patient, the second patient out of the St. Joseph's Hospital. And our goal when we lay hands on a patient is to be out of the hospital within 30 minutes.
Because we provide such critical care transport, we actually provide the ICU in the air to get the patient transported. Each flight, besides having a pilot, has 2 critically care trained nurses. So we really do bring ICU services to the patient.
What's in the back of the aircraft is a mobile ICU or an emergency department. If there's any medications that we need to be able to give them, we'll do that. We'll give them fluids. If they need fluids, if they need breathing treatments, we do all that while we're coming into the hospital. Stabilize and improve the outcomes of our patients.
With our 4 helicopter bases and our 2 Learjet bases, we are able to provide exemplary care to patients that have critical needs 24 hours a day, 7 days a week.
So a very brief synopsis of what we do, and we'll expand on that as we go through the program. Jeff, who is a star actor on that, is here today to talk about some things also. So our goal, our mission, our vision is to bring stability and peace of mind to the communities, and that we will be the premier air medical service in the country. And interestingly enough, The stability and peace of mind to our communities really is evident every single time we go out to a rural hospital. And their statement often is, "Thank God you're here," and then they leave, because they know that we'll take care of the patients for them. So, and we are currently in the process of looking for some people to add to our organization, and they are amazed by the number of flights we do. So Airlift is a busy flight program that's busy pulling people in from rural communities to the higher levels of care here within the metro area. And that's a service that we have liked to provide since 1982 when it was started. So what and who we are Air Medical Transport, and if somebody asks me what I do, I say I'm a flight nurse. And they look at me kind of quizzically, and they think, what a cool uniform, but they don't know what that means. And so my next step is, you know those helicopters that land at Harborview? That's what I do. I'm in the back seat. We're 24/7 operation, just like a fire department and the medics, and we have facilities spread across Washington along the I-5 corridor, and we also service Southeast Alaska. So the helicopters that you saw in the movie, two different kinds, but both of them are similar in their capacities and speed, and so we strategically place those along the I-5 corridor to meet the needs of the community. We currently have about 100 employees total, 81 nurses, plus pilots and mechanics that we contract with, people that are highly specialized in flying helicopters and jets. And those are Aero Air and Air Methods. And Air Methods currently is the largest provider of medical helicopters in the country. We have an advisory board that sits and helps us make the important financial decisions about which direction to move. And we have been affiliated with UW Medicine Health System. So when you go to the UW website, you'll see that Airlift Northwest is one of the entities. So why air transport versus ground? And there's lots of ground ambulances in the air area, but we specialize, like Jeff said in the video, that we're a mobile ICU or an emergency department. We bring the system to the patient. So we're trained by Harborview Children's UW, and that's our specialty, is bringing that next level of care to the patient and improving their outcome. And there's also a point at which you begin to think, was it faster to send my patient by air or ground? And that there's a cutoff point for that, and doctors that refer their patients have to think about that. So we are generally within a 30-minute radius. The other things we do is fly to islands. They take an hour by ferry, take us 6 minutes. So we really improve the time to getting into the facilities. This is a map of where we're located and the aircraft that serve them. Juneau, Alaska is about 900 miles away, so it's about a 2-hour flight for us in the Learjets. It's a common referral pattern to come down to Seattle, so we've tried to make that easy for them. This is pictures of all the different kinds of aircraft that we use. EC-135s is a common helicopter used in the air medical business. We also like the turboprop, which lands on shorter runways, such as in Sunnyside and other smaller communities in eastern Washington, along with being able to serve the islands up in San Juan's. And also, if the weather's bad enough so you can't fly a helicopter, we'll send a plane instead. So we've done lots of things to try and meet the needs of the communities. So this is a couple of pictures of us on scene flights and how we work closely with the providers out there, the medics. And again, Washington becomes very rural very quickly, and so we're there to work as partners with the EMS system and bring them into the best level of care they need. It may not be Harborview, but oftentimes it is. And we land just about anywhere. So this is, I'm not sure which mountain we're on, but one of the things we look at on snow is it packed hard enough to support the weight of the aircraft? So this is our Augusta helicopter. It has wheels that retract. So when you think about putting an aircraft that weighs about 6,000 pounds down in the snow, well, the weight on 3 wheels make it sink into the ground. Looking at flight volumes, Airlift does about 3,400 flights a year. Has been as high as 5,000 flights a year. That goes up and down depending on the economy and also the population of people around here. Rotary wing, we do about 30% in scene, and the rest of it is interfacility. So what you're looking at is moving those kids, those adults, those very sick people in from hospitals that don't have the same specialty services that Harborview, UW Children's, Swedish, or VM would offer. So core values of Airlift, our primary thing that we really talk about is being safe. And there's a recognized risk of helicopters flying, but we do everything in our power to make sure that we make safe decisions. And so pilots aren't told about the condition of the patient when they're dispatched on a flight. They're told where they're going to go and where they're coming back to, and they'll make the decision whether that's a safe flight to accept without knowing the condition of the patient to influence them. We pride ourselves on clinical excellence, and we really pull in the nurses that have a lot of experience. And when I was hired 16 years ago, our average years of experience for the group I was hired with was 18 years. So it's a job that lots of people like to have, but we really bring in the cream of the crop. So we are excited about the excellence that we offer as far as clinical skills. And access, we do everything we can to allow access for people, and that means if you call, we haul. We don't ask you if you can pay. We don't ask you if you have insurance. If you have a specialty need or need to be moved, we're going to help you get there. And finally, Airlift treats everyone with the same level of respect. And that comes with not asking what you do. There's no special preference for if you're a doctor or an actor or some rich person, or if you're somebody that had down on their luck out on the street. We're going to fly you and give you the same level of care that you need to get better and to get to Harborview or one of the other hospitals. This is a scene response with Grace Harbor, which calls us almost daily to the hospital, not so often to the scene, but this is how we work really closely with the group. And this was an auto accident victim out on a mountain road. So we've landed there and have gotten the patient packaged and ready to go. And it averages 10 minutes on the ground at a scene, 30 minutes at a hospital. And this is just another example of working out in the field. This was a logging, a forester that got injured logging, and able to let us land there, his friends and coworkers started cutting down trees for the helicopter to come in. So the pilot did a great job. We require usually about 100 by 100 area to land safely during the day. And these guys went to work to get their friend out of there. So it was pretty amazing. So the pilots do a great job making sure that it's safe to come in, and the crews watch out for trees and other obstructions. But this is one of the spectacular rescues that we do. So next I'd like to bring up Jeff Ritchie to talk about training, safety, and Jeff's been a regional manager for us. And I knew him before he was a nurse, so he's been around for a while, and glad to have him come up.
Thanks. So I'm going to talk about safety and some of the training that we do, not only just as the nurses, but also what we do to the EMS and EMS folks that are out there. So just up here, this is some of some more pictures, because we love to be able to show people pictures of what we do in action. This is up at Crystal Mountain, that far one up there, which is I love Crystal a lot. And this is up at Harborview. But that's our EC, the Augusta 109 power, and then the EC 135. So it's great on sunny days, which we've had the last couple days. So hopefully everybody's recharged for at least another couple months of the rain. So helicopter safety. So when I go out to EMS agencies or even to hospitals to talk about when the helicopter is coming in, one of the first things that I tell them is never approach an aircraft when the rotor blades are turning. That is the biggest thing. A lot of times what we will do is that when we land at a scene, we've got the fire departments trained so well that they will set up a barrier around where we're going to land. But if we see anybody coming towards the helicopter, I'll guarantee you that you'll have a nurse coming out to greet you to either stop you or tackle you before you get to the helicopter. And I'll show you the reason why that. So the other thing is that we fly two different types of aircraft. And so what I tell them is never go past the wheels or the skids of a helicopter without a flight crew member escorting you. And one thing that we do is we do not do any hot loading of our helicopters. And when I talk about hot loading, that means that the blades are turning. So that would be a hot load. At Airlift Northwest, we do not do that. So the blades are always shut down. And the nice thing about our newer helicopters, it takes 30 seconds to shut the engines down and stop the rotor blades. So it's really quick, as opposed with our older aircraft that we had, it would take 2 minutes to cool down. So it's pretty fast. I can barely get out the door before the blades are turned. And then never go behind any sort of aircraft, either a plane or a helicopter. Because we land at so many airports with our Learjets and our Turbo Commanders, we will have people that will come up and meet us because we need an ambulance to be able to get us up to the hospital. So what we do is we tell our EMS folks that we have to be completely shut down, and then we have actually at Boeing Field, we have a gate clicker that we open the gate for them after we've been out to be able to escort them into the airport. So what we need for a landing zone. So the fire department needs to set up at 100 feet by 100 feet day or night. Our landing gear and our skids are about 15 by 15 to be able to touch down that area. But then the next thing we need is we need a 200-foot barrier around there, and I'll show a picture of that. It needs to be clear of obstructions. So, and you looked at that, the last photo that Brenda showed you with all those tree stumps. So the pilot had to do a really good job of making sure that he got into that area, that he wasn't going to land on a tree stump that was going to pop up into the aircraft. So that is very important. Roadways, schools, parking lots, or fields are the best for us, and GPS approach. Our communications center can pick up a GPS from just by giving us an address. So if a 911 center calls us and said, we need you out on Bainbridge Island, and they will give an address. And then what they'll do is they'll put it up in Google Map. I'm not trying to plug Google, but we all know what we're going to do is Google Map will bring it up, and then we'll say, oh, this is what the GPS is for that area. And that's how we navigate actually all through Western Washington and Eastern Washington. So this is a picture of what we tell people, the 200-foot perimeter around, and then 100 feet by 100 feet day or night. And then the other thing that I want to really talk about is what we did. In 2006, up until 2006, we were flying at night with nothing, so unaided. So basically at dark, we would be out there just using our own eyes. Well, what happened is that in 2006, we added night vision goggles to all our helicopters. So that means that at nighttime, our pilots are on night vision goggles, our nurses are on night vision goggles, so that we can see where we're going even better than before. And I have a little video to be able to kind of show you what it looks like. And I'd like to be able to people to look up and see if you can see the light. Can anybody see the light on the unaided side? And this is what we see at night. So this is a huge safety piece for us. And I can tell you that I do not want to be able to fly at night without these night vision goggles. And that has been actually, when this was first introduced, this is what the FAA is recommending for all EMS helicopters. So we were at the forefront of this technology when it started. So, and that's just kind of depiction. There's a hiker with his flashlight. So anyways, pretty amazing. So, loading and unloading, what we do is we go over these type of things. This is the EC-135. This is one way that we will load and unload the helicopter. It's got a clamshell in the back, and we have a stretcher. So what we're able to do is we're able to load a stretcher into the helicopter, and then when we bring it out, it's got wheels. We can bring our equipment into the hospital or next to the scene of an accident, which is a great tool for us, and it's got all our equipment on there, and our pilots there will help us load those patients. This is our Augusta helicopter, Augusta 109. It's got a little bit different loading system. It loads from the side. And also, we need to use stretchers to be able to move our patients around on that. It's not quite as easy. It has no wheels for us. But if you notice, it's all our bags are on the top. Let me talk briefly about EMS agencies. The EMS agencies in Western Washington, Eastern Washington are very, very important to us. And we work very, very collaboratively with them. We have set up an Airlift Northwest EMS advisory board, which I actually chair that advisory board. We bring in chiefs from San Juan County, Mason County, and all over Western Washington. And what we do is they can make suggestions of how we can do our job better. And it's really key for customer service for us. So we're very collaborative in what we're doing. The other thing is our scene calls that Brenda talked about, 30%, that all comes from emergency 911 centers. So that's someone picked up a phone, dialed 911, they activate Airlift Northwest along with the medic unit that's going out to that accident or to that cardiac patient. We bring our patients to trauma centers. Harborview is level 1 trauma center in the WAMI region. So a lot of our flights go to Harborview Medical Center, but we also take patients to anywhere the referring doctor or the referring paramedic wants the patient to be able to go. The new technology that's out there what I kind of talk about cardiac and stroke as being the new trauma. Cardiac and stroke, because we all know that time is muscle or time is brain tissue. And so we're seeing an increase in helicopter EMS with our cardiac patients and our stroke patients so that we can get them to the cath lab within 90 minutes or into a level 1 stroke center for the things that we need to be able to do. So interarterial thrombolytics and going to the right specialists that are here in Seattle. So we work very collaboratively. It's very great. So here's another map of where we're at. Bellingham, Arlington, Seattle, and Olympia. And then next, I'd like to be able to introduce Joanne Price, who's our clinical educator, and she's been with us a long time, just as long as I've been here. So, Joanne Price.
Good evening. So many people ask, well, how do you become a flight nurse? And Airlift Northwest runs a particular configuration or model where we run 2 flight nurses. Other programs may run a flight nurse and a RT, a respiratory therapist. Others may run an RN and paramedic, and some places may still put a physician on board as well. But we believe in the value of nurses, and so we run a 2-nurse program. You've all heard the phrase, the right stuff. Well, we really try and hire the right stuff. And it really is a vigorous process to hire a flight nurse. When they come on for their interview, first of all, they have to have the experience behind them. So yes, they have graduated from a program, but they also have to have an expertise. And we're looking at a minimum of 4 years up as high as Brenda had said, someone up to 18 years of experience. And many people go into nursing school with the idea, I want to become a flight nurse, and they'll ask us, well, where do you start? And it could be in a trauma unit. But it also, if you want to hire on as a pediatric or neonatal nurse, then you'll be looking at a neonatal unit. And we want you to be a specialist at what you do. So it's not bouncing around and becoming a jack of all trades, because that's what you become when you come to Airlift. But we want you to be very good at what you do. It can be a cardiac specialist, or it can be the pediatric specialist. But it's just that specialty and being so comfortable with what you do in nursing that you then can practice autonomously. And we really do practice autonomously when we're there, when we're up in the air. So you come in for the interview, you get a test, because we just want to know what your knowledge background is. Then you have an interview, and it can be a panel from anywhere from 2 people up to facing a panel of about 6 or 7 people. And we ask behavioral questions. Not what would you do, but what have you done? For example, tell me about a time and experience where you've had conflict at work. Give that example and tell me how you navigated that problem. We want to know how you think, and so that can you think on the job, because you're going to be solving a lot of problems by yourself, out where the phone's not working, the satellite phone's not working, your aircraft breaks down, you've got the patient on board, what do you do now? Of course, the aircraft never breaks down, it never happens, but you need to be thinking of those things. And then you get a simulation. We take you out to the aircraft, we put a mannequin on board and give you a scenario, and you need to work through it. So they come out kind of thinking, wow, that was tough, but it really shows that they have what they need to come on board at Airlift Northwest. Once they come on board, we send them a letter saying, don't panic, you're going to be fine. They go through up to 3 weeks of didactic, of classwork, and you may be the neonatal nurse, but you learn about taking care of the 90-year-old patient that has a dissecting aortic aneurysm. And then the adult nurse sits there and gets told about the 24-week infant that they're going to be helping taking care of. And that's where they normally try and beat feet to the door. And that's why I close the door and say, no, you're staying. And you're going to learn about these infants, because you're going to be on board with the neonatal specialist, and you're going to be part of the team. And teamwork is so important at Airlift Northwest, and we value all the expertise that they bring with us. Once you've had the didactic, we look at individual needs. So if you've been a pediatric nurse for 10 years, but you need some more neonatal experience, we'll put you in the neonatal ICU. And so that may be from 2 weeks up to a month if you need some extra time or if you identify needs. You end up working in the OR to get intubation experience and other clinical needs. Once you've had some extra clinical, then we team you up with 2 nurses for the first 3 weeks. So if you're the adult nurse, you're going to be teamed up with 1 adult nurse plus a pediatric nurse, and they're going to be joined at the hip basically for 3 weeks. And so for the first few flights, all 3 of you are on the aircraft, all 3 go out to the aircraft, and you can observe for a couple of flights, and so you can see how the team works. And then after that, then you are part of that team. And you're going to be going with the adult person on adult flights or the pediatric nurse on pediatric flights. And you're going to be working with them. The preceptors have one of our most experienced nurses at Airlift Northwest. And they're there not only to help look after the patient, but they're there to keep the orientee safe. Because you may be the expert in the hospital and you've been so used to being the go-to person in the hospital. And all of a sudden you're in the back of the aircraft and you can't do up your helmet. And you're thinking, I don't understand, I'm good at what I do, and I can't even remember, how to put my seatbelt on. So it's very difficult to transition from being an expert in your field, which is why we hire you, and we know you're good at what you do, to suddenly being really out of your comfort zone. Because being in the aircraft, particularly at night where the lights are off, and it's bumping around, and you're trying to start an IV, and you're thinking, serious? And we're going, yep, come on board. So you're with that preceptor for 3 months. And then after the 3 months, you are then with senior people for another, at least another several months up to a year. We do night duty, except for new people, we believe in not only keeping you safe, but making sure that you are not stressed, because a stressed person cannot work safely. So unlike a lot of hospitals where you're new and you get stuck on night duty, I don't want you working at night in the dark where you can't see or you get woken up on your pager and you're supposed to be in your uniform, hopefully with your legs in the right place, and out in the aircraft and trying to work. So for 3 months, you don't work night duty because that's too stressful. And then for another 6 months, you don't work 24-hour shifts, which is what we do as well, because that's stressful. So we really try and decrease your stress level and make you safe, because we want you to do a good job. So one of the challenges that we have at Airlift is to keep up with technology. And so Airlift has really prided itself on having equipment that really it keeps up with whatever hospitals are bringing in. And one thing to show you just the difference of what's been going on is this is a laryngoscope, something that you'd usually use to intubate patients. Well, this is what we use now. And for those that are used to video games, this is like a video game. And what you do is you put this in the patient's mouth and you can actually see what you're doing, and everyone else around you can see what you're doing as well. And so you're actually looking at the screen, you're not looking at the patient, where beforehand you are looking down the mouth of the patient and you didn't see anything else around you because this is what you're looking at. But now you are absolutely looking at the screen, your hand's doing this, you're looking over here. So the Generation X does really well with this. And the rest of us is going, where am I looking? But it's part of the training, but this is called a glide scope. And the idea of the glide scope is not only can you see what you're doing, everyone else around you can see what you're doing, go left, no, go right. But it also increases your success. You're able to keep your skills up a lot easier. And it hopefully will increase our ability to intubate someone on the first attempt, the first pass attempt. That decreases trauma to patients. It increases or decreases the time for intubation, and will actually decrease our time on the ground or in the hospital so we can get the patient to where they need to be quicker. And that is part of one piece of technology. It's not a cheap technology, but it's something that we felt was very important to improve patient safety, and so we invested in it for that plus the baton, it's $13,000, and we invested in that throughout the organisation. So then there's the ongoing education. So you have your original training, but there's ongoing education. And as you can see, there's a lot of certificates that we keep, and every single nurse is expected to keep all these certificates up at all the time. And what's interesting is the professional certification, a critical care registered nurse or an emergency nurse, you'll often find that the nurses at Airlift Northwest does not just have one, they may have two or they may even have three. Because we want to have as much knowledge as we can, because we are out there and rural hospitals and rural areas very much depend on us, and we want to have that knowledge for them. Thank you very much.
Hello, my name is Julie Hoffman, and I've been had the pleasure of working here at the university since 1986. I graduated from Seattle University and started working at Harborview. I started working as a flight nurse in 1993, and have currently I'm working as a regional manager. I just wanted to say what a pleasure and a privilege it is to work for the university, and it's such an opportunity to, in medicine in general, I noticed we have a lot of different types of medical people here, but I wanted to invite the students out there thinking about their careers that in nursing alone, there's so many opportunities, and flight nursing is one of those that is just amazing. And so I invite you to think about nursing in general and all the opportunities to have, and then even think about flight nursing, because it is really one of those jobs that it's just been, every day is a blast, every day is different. So hope that you'll think about that. Not to reiterate the training and the education that we have, but it's really great to know that when I'm looking at the person across from me in that helicopter, that they have a lot of experience, because what Brenda said, when we get out there, it is just that person and me, and we may be taking care of that patient, and they'll say, oh great, you're here, and they do leave. And so we really need each other to bounce ideas off and take care of those patients. We've really been pushing the UW Medicine system, and we've had a lot of training with UW Medicine, and we are really bring that system to the bedside, and I'm really proud to be able to say that. Here's an example of some of the patients we fly, and I'll tell you a little bit about the breakdown specifically. About 5% of our patients are obstetric, 5% are neonatal, pediatric under the age of 21. We do a fair amount of trauma. A lot of the trauma goes to Harborview. We do 25% medical, and then the rest is 10% cardiac and stroke. And like Brenda said, we do about 3,400 flights a year. So I didn't break down specifically the numbers, but the other thing, we don't triage whatsoever. When we get the call, the medics make the decision with their medical control about where we pick up the patients and where we will take them. And the last time we checked, we went to, specifically for hospitals, we have been to at least 77 different hospitals and admitted to 35 different hospitals just in Washington and across the United States. So we really do bring patients anywhere that they want to go. So just to give you kind of a day in the life, we do 12 and 24-hour shifts. One of the bases in Olympia, it's a 24-hour shift. We start at 9 a.m. The nurses come in, kind of report off from the previous crew. We do our NARC count. We check our aircraft. We make sure we have all the equipment. We check our stock. We review all the charts. So we break those down in different ways. We review the previous day's charts, and we're there waiting for a call. And specific for a helicopter, our goal is to be in the air within 10 minutes when we get a call. So I'm going to give you an example of a specific day. Just on any given day, like in the summer, we can do 3 or 4 to 5 flights, and each flight takes 2 to 3 hours, and in the winter it drops down to maybe 2 or 3. So on this particular day, in this example, the nurses, we have rest station, rest quarters. They were in bed asleep, and they got a call at about 12:30 at night. And on this night, the pilots, will get up and check weather, especially in this is December. So the pilot gets up and checks. The nurses jump up, get dressed. I always brush my teeth. I think how offensive to have to smell my breath in your face. But we get out to the aircraft, and like I said, we really do want to be in the air within 10 minutes. The pilots do the weather check, and the pager, all it says is what I have written up there. In this case, it was Airlift 3, Vashon Island, and where you're going to land. They have no idea what they're going to get. The pilots, and the reason is for that is we don't want the pilots to have any personal influence as to a go or no go. We don't want them to say, oh, God, that could be my mother, or that could be my sister, oh, it's a baby, or it's a kid. They just need to know that it's safe to go. So when they get the call, that's all they see. So this is the call once they got the thumbs up to go.
Kyle Center 30, 3 souls on board, Bravo 3 over 2.30 till burnout en route to Vashon Island, showing 24 minutes, ready for report. Airlift 3 received 24-minute, time now is 0044. You're going to, actually your flight number is 5792. You're going to Vashon at Docton Church. Destination will be Harborview, patient 130 pounds. Ground contact is 855 on state ops, channel 231 for ongoing CPR. 3 copies, 835 on channel 231.
So on this particular flight that day, the 2 nurses had more than 50 years nursing experience and approximately 30 years flight nursing experience specifically. The pilot we had has military background. He's flown in both the last 2 wars, both in Iraq and Iran. So en route, the nurses kind of make a talk about what they're going to do. They know they have a CPR patient. There could be 100 reasons why, but we have something called our Blue Book. It's really our Bible, and we keep all our policies and procedures in there, and it gives us a reference point for any given day to a type of patients to make sure that we know we're following our protocols, give us ideas, you know, for medications they might need, reviews of dosages, etc. So they'll review that. The flight time was approximately 14 minutes, and we were on the ground meeting, I think it's the Vashon Island Medics, which is part of the King County Medic 1 system, and this patient had been intubated, had gotten 3 or 4 shocks, a couple of rounds of code medications, epinephrine, lidocaine, and so she had been stabilized. Then we loaded her and flew. It's about a 6-minute flight from Vashon Island to Harborview. We put the patient in the back of an ambulance. We land right at the back there and then admitted to Harborview. From the time of call to the admission to Harborview was less than 1 hour. So what we were doing in the back of the aircraft is we review that we'd kind of had a good plan for what the patient's needs and issues were. Like we've talked about, we are a flying intensive care unit, so this patient was put on our ventilator. We have a LifePak 15 monitor. We could do a 12-lead EKG if we needed to. We continued on with the medication she's got, monitor her heart and blood pressure. And oftentimes, most of the time, we will give we'll call in the air to Harborview for the medical control and just say, Medic 1 doc, this is Airlift 3. We're en route with the patient, 42-year-old female, status post-CPR, ventilated. She's stable. Here's her vital signs. We'll be landing in 6 minutes. Over. Rather than me telling you specifically what happened then after that, I would like to introduce to you Lisa Freeman, who is this lady who has, we had the honor of flying, and she's here to tell you about her experience. Lisa?
So they gave you a little bit of a background, and what I'd like to do is talk about, well, first of all, how lucky I am to be here, and also about the chain of survival, which is critical in surviving a cardiac arrest, which is what I did, thanks to the wonderful people of Medic 1 and Airlift Northwest and Harborview. I guess the first stage of the chain of survival is early recognition, which I failed miserably at. I'm 42. Female. The week before, I was having right-sided chest pain. I ignored it. Figured I was 42 and female and probably had a gallbladder issue, and it wasn't bad enough to do anything or have my gallbladder taken out. That was the last thing I remember, driving home from work at about 7:30. I rested about midnight that night. And so first and foremost, women can present cardiac symptoms very differently than stereotypes. This is where I also cringe and tell everybody I've been a registered nurse for quite a few years. So early recognition. And then also basically next is calling 911. If you're like us, we don't have a landline. My husband lost about a minute and a half looking for a cell phone. So keep one on the counter, fully charged if you don't have a landline. Medic 1 arrived. Prior to that, my husband started CPR, and a volunteer fireman who lived down the road came and helped. They did CPR, the notes say, for approximately 20 minutes, which I'm very, very fortunate for surviving CPR for 20 minutes with supposedly my brain still intact. And I was defibrillated 4 times. And then the next stage is the advanced care, which is Medic 1, Airlift Northwest, and Harborview. And just some interesting facts that I found after I got out of the hospital, which waking up in the Harborview intensive care unit is, well, I can't tell you what I said to the nurse who told me where I was and why I was there, because it's not appropriate. Nationwide, the survival rate for cardiac arrests is about 5%. What happened to me, my left anterior descending artery, which some of you may or may not be familiar with, it's called the Widowmaker, because it's very, very deadly when it becomes clogged. That became clogged, and they did CPR, like I said. Medic 1 came, defibrillated me 4 times. They met up with Airlift Northwest and was then transported to Harborview, where I had 3 stents placed. And according to my chart, which I got, I think I arrested right at about midnight. By 3:20 in that morning, I was moving all extremities and nodding appropriately to questions. So, very, very lucky. Wanted to again talk a little bit about how you can improve your chances. First of all, I live here in the Northwest with Medic 1 and Airlift Northwest. And Harborview, survival rate's about 50% is what the data I saw, compared to 5% nationwide. Compressions. Can I say that again? Only about 1/3 of witnessed cardiac arrests of people receive CPR. Like I said, as a registered nurse, my priority is making sure my CPR card was current, and I knew how to do CPR for someone. I never really thought about the people around me, whether or not they knew how to do CPR. And I was quite shocked to learn that hardly anybody in my family knew CPR once, all the phone calls went out, which they all do now because they're scared to be around me. But compressions. If you don't know CPR, go out and get your card. Make sure your family knows CPR. Make sure your people in your book club know CPR. Defibrillation, a portable AED costs about $1,000. And that early defibrillation is going to be a key to surviving. Most health clubs nowadays have them. Vegas casinos are actually another really great place to survive a cardiac arrest. Surprising. And O'Hare Airport, and I believe it's the Melbourne Cricket Club also has a very high rate if you happen to be in Australia. I guess that's really about all I wanted to say is, take the time, keep your phone out. Oh, address. Addresses on your mailbox, visible. Make sure they're huge is another key so the Medic 1 can get to you. Support Medic 1, Airlift Northwest, and Harborview. They may save your life, and they did mine, and I'm very, very grateful. And thank you for having me.
And we're excited that Lisa's here, and actually we're bringing her to the Women's Cardiac Health Luncheon on Friday in Sequim to continue to promote women's health and cardiac health. So I'm going to open it up for questions.
I'd like to start by thanking you for giving this presentation on Airlift Northwest. I had no idea what you do. Even though I've got a lot of medical background, I had no idea, and I had no idea you have an ICU in the back. Thank you. My question is, you mentioned talking to the pilot and letting that pilot decide whether it's safe to fly or not. You've also mentioned flying into areas like Sunnyside. I'm from Eastern Washington. I know what that means. And I guess my question is, how often do you decide it isn't safe to go? Can you say something about the, and if you're going to San Juan Islands, for example, is it likely to be so fogged in? Can you say something about times when you don't go because of air safety issues?
Sure. When we ask pilots to do a weather check, we're looking at visibility. We're also looking at rain or snow. Helicopters aren't able to de-ice like planes are, so you don't want to send them into conditions where there's going to be ice collecting on the blades. So our alternatives then are working with the providers that are out there and arranging alternates, either ground or ferry, or sending in a plane that has de-icing capabilities.
So could your plane with de-icing capabilities usually get through, even say, if you're going to Eastern Washington and there's a terrible storm on the mountains, are you likely to be able to get a plane through under those conditions?
Right. Yeah, we are likely. That's why we keep planes in service, is we can fly above the weather if we have to in the planes. What limits us is the same thing that limits the bigger planes at the runways. It's visibility and how well can your plane stop on an icy runway. So rare occasions, probably 2 or 3 days a year, that there are certain airports that we can't get in. Wenatchee comes to mind just because they tend to get a lot of ice. Sunnyside occasionally because they have a shorter runway, but then we land in Yakima and ambulance down to Sunnyside to pick up the patient.
How about, say, Tri-Cities or Spokane?
Tri-Cities and Spokane are great resources. They have huge airports. I mean, Spokane has a military base there that we can land at if the regular airport is closed. They also have a second field in kind of suburban Spokane, so to speak, like Geiger Field, and then Coeur d'Alene. So Tri-Cities, again, big runway and not usually a problem, well maintained.
And the San Juans you can get in and out of fairly readily?
San Juans, we either use the turboprop, which is the plane that has the blades on the outside, or the helicopters. It's primarily a helicopter response, but yeah. We turn down maybe 150 flights a year out of 34 or 3,500 calls a year. So we generally are able to meet the needs.
Okay. Thank you very much.
Thanks. So the question is, what if the patient doesn't have insurance? It's a good question. We don't ask. If it's an emergent flight, we'll just haul them, and we'll work with the patient or the family afterwards. We often help them with Harborview or UW work with the state to get Medicaid. Cost really ranges, but I'll tell you the helicopters burn 1 gallon a minute of fuel. So you're looking at anywhere from 60 to 70 gallons for a trip, so depending on how far you're going. So I'm going to tell you the range is really large, so somewhere between 10,000 and 60,000, depending on the distance.
And we're going to let you go home and study for the next set of exams. And we hope you come back next Tuesday. We have another round of fabulous talks. And you all are dismissed.